Hello everyone, today we'll be discussing Polycystic Ovarian Syndrome, which we commonly call PCOS or PCOS. Polycystic Ovarian Syndrome (PCOS) was originally described in 1935 by Steen and Leventhal as a syndrome that is manifested by amenorrhea, hirsutism, and obesity that associated with enlarged polycystic ovaries. This heterogeneous disorder is characterized by excessive androgen production by the ovaries mainly. PCOS is a multifactorial and polygenic condition. Diagnosis is based upon the presence of any two of the following three criteria: 1. Oligo and or anovulation; 2. Hyperandrogenism, which is clinical and or biochemical findings; 3. Polycystic ovaries. So any of the two out of the three will give you a diagnosis of polycystic ovarian syndrome. Other etiologies include congenital adrenal hyperplasia, thyroid dysfunction, hyperprolactinemia, Cushing syndrome. These need to be excluded before you make a diagnosis of PCOS. The incidence varies between 0.5 to 4% and is more common amongst infertile women. It's quite prevalent in the young reproductive age group, about 20 to 30%. Polycystic ovary may be seen in about 20% of normal women. Pathology. So typically the ovaries are enlarged, ovarian volume is increased greater than 10 centimeters cubed, stroma is increased, the capsule is thickened and pearly white in color. Presence of multiple, which is greater than 12 follicular spheres measuring about 2 to 9 millimeters in diameter, are crowded around the cortex. Histologically, you may note thickening of the tunica albuginea. Cysts are follicles at varying stages of maturation and atresia. This theca cell hypertrophy, stromal hyperthecosis. Patient may present with features of diabetes mellitus, which may arise due to insulin resistance. Clinical features include, so the patient will complain of increasing obesity, which is more in the abdominal region, about 50%, menstrual abnormalities, which is 70% in the form of oligomenorrhea, amenorrhea or dysfunctional uterine bleeding, and infertility. Presence of hirsutism and acne are the most important features, which is present in about 70%. However, virilism may be present but is rare. Acanthosis nigricans is characterized by specific skin changes due to insulin resistance. Skin is thickened and pigmented, may appear grayish-brown. Commonly affected sites are the nape of the neck, inner thighs, groin, and axilla. So when you're examining a patient, you need to look at these areas for acanthosis nigricans, which is thickening and darkening of the skin. Then hair and syndrome in patients with PCOS is characterized by hyperandrogenism, insulin resistance, and acanthosis nigricans. Internal examination reveals bilaterally enlarged cystic ovaries, which may not be revealed due to obesity. When you do a sonography, so transvaginal sonography is especially useful in an obese patient. So of note will be ovaries are going to be enlarged in volume, as you can see on the second diagram. Then there will be an increased number of greater than 12 of peripherally arranged cysts, 2 to 9 millimeters are noted. Serum values of note is luteinizing hormone level is elevated, and or the ratio of LH to FSH is greater than 2 to 1. Raised levels of estradiol and estrogen, the estrogen level is markedly elevated. SHBG level is reduced. Hyperandrogenism, so mainly from the ovary but less from the adrenals. Androstenedione is raised. Raised serum testosterone levels of above greater than 150 nanograms per deciliter and dihydroepiandrosterone may be marginally elevated. Insulin resistance, this can be noted by raised fasting insulin levels of greater than 25 micro international units per ml and fasting glucose to insulin ratio of less than 4.5, suggests insulin resistance. Levels of serum insulin response greater than 300 micro international units per ml at 2 hours post glucose 75 grams load suggests severe insulin resistance. When you do a laparoscopy, you may take note of bilateral polycystic ovaries, and these are characteristic of PCOS. Management of PCOS needs individualization of the patient. So what do we mean by individualization? So it depends on the presenting symptoms, such as is it a menstrual disorder they're presenting with, is it infertility, obesity, hirsutism, or a combination of the above symptoms. So of notice, patient counseling is one of the most important things, and treatment is primarily targeted to correct the biochemical abnormalities. So biochemical abnormalities that are associated with PCOS include hyperandrogenemia, hyperinsulinemia, hyperlipidemia, high serum estrogens, androgenic follicular microenvironment, hyperprolactinemia, insulin resistance, hypersecretion of luteinizing hormone, low serum of SHBG, low FSH, low serum progesterone. So under the management, weight reduction in obese patients is the first line of treatment. So you try to aim for a BMI below 25. This usually improves menstrual disorders, infertility, impaired glucose tolerance, hyperandrogenemia, which is hirsutism and acne, and obesity. So weight reduction about 2 to 5% improves the metabolic syndrome and reproductive function. So our first aim is to make sure our patient has a normal BMI, okay? Then for patient that does not desire fertility, how do you manage the hyperandrogenemia? So combined oral contraceptive pills are effective. Progestin suppresses LH and estrogen improves SHBG, reducing free testosterone level. Newer progestins such as desogestrel are best suited. Then hirsutism, that is due to anovulation, high androgen and insulin levels, decreased hepatic SHBG production, and also due to genetic sensitivity of hair follicles to androgen. Correction of metabolic syndrome will improve the above symptoms. And anti-androgens such as cyproterone acetate, spironolactone, flutamide may be used. So I've noticed all these are usually used if fertility is not desired. Okay. Then for the metabolic syndrome, hyperinsulinemia, insulin resistance causes the hyperandrogenemia. Insulin resistance is associated with diabetes mellitus, central obesity, dyslipidemia, and hypertension. So you can give metformin, which increases insulin sensitivity, decreases weight and BMI, and also reduces LDL cholesterol, blood pressure, and the risk of developing diabetes. So metformin is one of the lines of treatment. So metabolic syndrome, how do you diagnose that? Triglyceride levels of above or equal to 150 milligrams per deciliter, HDL cholesterol of below 50 milligrams per deciliter, BPs of above or equal to 130 over 80 millimeters mercury, fasting glucose of above or equal to 100 milligrams per deciliter, abdominal waist circumference obesity above 88 centimeters. Presence of any three abnormal findings out of the five will give you a diagnosis of metabolic syndrome. Hyperinsulinemia contributes to hyperandrogenemia in women with PCOS. Hyperinsulinemia increases the risk of dyslipidemia, cardiovascular disease, and diabetes mellitus. Insulin resistance is the principal abnormality that leads to metabolic syndrome. So on surgery, you can do laparoscopic ovarian drilling is done in cases that are found resistant to medical therapy. It has replaced the conventional wedge resection of the ovaries. Pregnancy rates following ovarian diathermy are quite high. Bariatric surgery may be indicated in some PCOS women who are morbidly obese. If the patient desires pregnancy, we need to know that chronic anovulation is the commonest cause of infertility in PCOS. Improvement of metabolic syndrome is essential, so you first start by improving the metabolic syndrome. Then ovulation injection is usually achieved by clomiphene citrate, following correction of other biochemical abnormalities. So in this case, if a patient desires pregnancy, you give them clomiphene citrate. You ensure that their BMI is within normal range. If in unresponsive cases, pure FSH or HMG along with HCG may be administered backed up with monitoring facilities. Insulin sensitizes women with PCOS and hyperinsulinemia with a BMI of above 25 ovulate satisfactorily when clomiphene is combined with metformin. So you can give clomiphene and metformin, and that usually helps. Metformin improves metabolic syndrome by reducing all the parameters such as weight, BMI, blood pressure, and lipid abnormalities. So how do you give it? You give 500 milligrams thrice daily. Then pioglitazone and rosiglitazone are also being used in cases that are resistant to metformin. However, the first line is still metformin. So that's all about PCOS. If you like the video, please like, subscribe, and comment. Thank you.